congestive heart failure. You are very familiar with this in undergraduate curriculum, but the key point is that the heart fails to pump blood adequately, and it's increase of the workload of the heart, and heart slowly will get thickened secondary to increased workload. The myocardium may get thickened, and symptoms may increase. Symptoms may include the gradual increase in dyspnea, patient not tolerating the walks, tachycardia, tachypnea. Also, another hallmark of this is paroxysmal nocturnal dyspnea, or PND. And you need to know that the paroxysmal nocturnal dyspnea is sudden waking up short of breath in the middle of the night, PND. Congestive heart failure will also result in neck vein distensions, edema in ankles and lower legs, pulmonary edema, right-sided versus left-sided will have, of course, the different manifestation of the edema. If the right-sided heart isn't functioning well, then edema will be, of course, peripheral. Left-sided will result in pulmonary edema. You often will see combined right-left-sided failure, and patient may present with edema peripherally as well as edema in pulmonary system. Diagnosis by history and physical, chest X-ray and EKG. And chest X-ray will reveal increased size of the heart. So how you can decrease the workload? Of course, decreasing the workload may be done by reducing the vascular volume and by introduction of diuretics. Another important introduction here is to introduce low salt diet, 2 grams or less of salt, and fluid restriction. Cardiotonics such as digitalis or digoxin can strengthen cardiac muscle and strengthen the contraction, so they would help the heart to pump more effectively. But again, here the diet may play a significant role. 2 grams of salt is one of the important things you can do for your patient, but however, everything has salt nowadays, and restricting the salt is very difficult. You need to teach your patient to read the labels and calculate. Less than 2 grams will become very difficult task, but still possible. And reducing the salt may significantly decrease vascular volume and decrease the workload on the heart. Cardiomyopathies are diseases of the heart muscle. There will be what happen, the heart muscle for one or the other reason become dilated, enlarged, and thin, flabby. There is no cure per se, and it may certainly lead to myocardial infarction, congestive heart failure, and death. Carditis is an umbrella term for pericarditis, myocarditis, and endocarditis. Depending on the onset of the place, it gets its name. Pericarditis, pericardial sac, may be occurring and causing constrictive pericarditis, and it will be consequence of some type of infection and affecting the pericardium. Often there is an introduction through some kind of window, which by window I mean respiratory, urinary tract, or skin infection, will introduce offending agent to the heart and would cause inflammation or infection. Treatment for all types of carditis fairly the same: antibiotics, analgesics, and antipyretics. So the diagnosis can be done by imaging studies, ultrasound, and introduction of antibiotics most likely may resolve the disease. The pericarditis may have the pain in in chest area, have significant chest area pain. However, positional changes may alleviate the pain. So when we comparing this with myocardial infarction pain is not modifiable by positional changing or pressing on the chest area. It has life of its own. But pericarditis pain, again, this is a good test question on the board or anywhere else. So pericarditis pain, you may modify it by positional changes, and while myocardial infarction, you cannot. Valvular heart disease may be a consequence of rheumatic fever as well as endocarditis, because when endocardial lining inflamed, the deformities of the valves may occur. And the main point of this slide is to tell you that diagnostically you may diagnose this by auscultation, and you will hear murmurs of types. And murmurs are the swooshing sound when the heart valves close not completely, or there is a stenosis of the valve, then you may hear a murmur. Arrhythmias, abnormal heart rhythms, and I do not want to spend in here long time on arrhythmias because it's certainly a separate part of cardiology. But arrhythmias can be abnormal. Arrhythmia is always abnormal, but some of them can be fairly benign, while others are, like such as ventricular fibrillation, can be deadly. So arrhythmias should be diagnosed and treated, and whatever the treatment is it medications or even using the defibrillator, but still it has to be treated. And defibrillators may be implanted to deal with life-threatening arrhythmias, and this is very generalized coverage of the topic, but at this point, considering so much time was spent on this in undergraduate studies, I do not want to burden you with this topic again. And most of you are working to some extent in, not most of you, but some of you work in cardiology, so this will be truly a rerun of the information you already know. So, but the generalized way to say flutters or increase in heart rate, maybe atrial flutters versus atrial fibrillation. Flutters still may be some kind of pattern be noticed, and you can see up to 350 beats per minute. When you see heart blocks, it's an interruption in conduction system. Heart blocks may have fairly regular pattern, and while flutters are very irregular, and fibrillations on the other hand, it's completely irregular pattern. So atrial fibrillation, the way to describe it will be, when you describe it, you can say irregularly irregular. Heart blocks will be regularly irregular. Then the heart blocks can be first degree, second degree, AV block, or bundle branch block, different type of heart blocks. But again, considering the limitations of the time, I will not be describing each one separately. And here again, first, second, third degrees, premature contractions, atrial or ventricular. So treatment may include, what are the treatment? Treatment may include the medication as well as implantation of pacemaker defibrillator depending on the arrhythmia.